Now may I invite my dear colleague, Professor Shahira Rashad, to talk to us about the optimum refractive solutions for childhood glaucoma eyes, if any. Please,
شكرا
Professor
دكتور
Shahira.
نادر على الدعوة.
Thank you very much.
Childhood glaucoma is divided into primary and secondary, with primary congenital glaucoma is the most common cause of childhood glaucoma. According to the visual outcomes, we can divide the patient into either poor vision, with poor visual outcome with vision less than 660, and this represents about 45% of the cases, and fair from 660 to 618, good with vision more than 618. In some studies, it is up to 38% of the patient will end with good visual acuity, but this depends on the region because there is large regional variation, with poor vision reported more in countries with lower income. The visual rehabilitation for this group will depend on the vision. The poor visual outcomes is usually associated with unilateral disease, patient who had multiple surgery, poor vision at diagnosis, and ocular comorbidities, and the neonatal onset. And the cause of poor vision in this patient will be mainly the amblyopia, corneal opacification, glaucomatous optic atrophy, and the visual deprivation nystagmus. The refractive solution for this patient will be either corneal transplantation if the patient has corneal opacity and low vision aids. 77% of the patient will have corneal opacification, mainly in the form of herpes striae, scarring, and the corneal edema. But before proceeding with keratoplasty in this patient, we have to balance between the risk of amblyopia and the high-risk operations that may not improve vision in this patient. We can do either PKB or DSEK according to the affected layers. Penetrating keratoplasty can be done for patients with corneal opacity and endothelial dysfunction, but there is a very high risk for failure in this patient because of the robust immune response that will lead to graft rejection, difficulty with examination compliance, reduced corneal and scleral rigidity will result in high irregular astigmatism post-operatively, and this may exaggerate the existing amblyopia. The glaucoma by itself is a high risk factor for graft failure. Also, the keratoplasty can lead to progression of glaucoma from the long use of steroid, from the peripheral anterior synechia, and from the distortion of the trabecular meshwork by sutures. So we have to consider the condition of the eye, the unilaterality of the disease, the structure of the anterior segment, and the visual prognosis of the patient. The SEC, which is transplanting only endothelium and stroma, is reserved for cases with endothelial dysfunction without significant corneal opacity. It has the advantage of lower graft rejection rate, lower suture-related complication, minimally surgically induced astigmatism, and quick surgical rehabilitation. But we have challenges. If the child had the tube, this will increase the risk of graft failure, and if the glaucoma surgery can lead to escape of the air from the anterior chamber, which is injected at the end of the procedure to keep the implant in place, and this can increase the rate of free bubbling. The main visual rehabilitation for this patient will be the use of low vision aids. The goal is to improve learning and improve child academic performance. The simplest is to use spectacles, higher plus power in glasses. This will improve the magnification and it is easy for the child to use. The amount of aid power will be equal to the inverse of the visual acuity. So if I have a child with 2200 visual acuity, this means we need 10 diopters of aid in his glasses. Other is like magnifiers for near task, telescopes for distance vision, either handheld, clip-on, or mounted on spectacles. For patients with good visual acuity but severe visual field loss, reverse telescopes can be used. It reduces the image size, so it will double the field of the view of the child, and this can be used in patients with glaucoma and retinitis pigmentosa. Some electronic device can help the child to learn better, either using video magnifier, which projects the enlarged image on the screen, and auditory tools will help with text-to-speech and speech-to-text function. The other group of patients, which are the good visual outcomes, they have vision better than 0.4 decimal. The spherical equivalent in this patient can range from -4 up to 20 diopter and sometimes more. These are the patients who who were managed well, diagnosed early, have clear cornea at presentation. And when these patients become adults, they can ask for refractive surgery, or sometimes doctors recommend refractive surgery to this patient. So can this patient have any refractive procedure? The simple answer is no. Corneal refractive surgery should be avoided in this patient because the biomechanical properties of the cornea is altered. This patient have flat keratometry, had large cornea from the stretching of the eye from the elevated IOP. We have mechanical stress on the cornea will cause tears in the descent membrane. And this cornea behaves in a similar way to keratoconus because they have reduced corneal hysteresis and they have topographical changes of high posterior corneal elevation. So any corneal surgery in this patient will be unpredictable and can result in many complications. ICL sometimes is suggested for this patient to correct their high myopia, but glaucoma is an absolute contraindication for ICL surgery. Also, the sizing and folding of ICL will be problematic because they have a large wide to wide diameter. This patient already have low endothelial cell count, and in general, the higher degree of preoperative myopia is associated with higher rate of complication of the ICL, so ICL should be avoided. Refractive lens exchange for the high myopia is also should be avoided, and lens surgery should be reserved for patients with visually significant cataract. There are many problems for doing surgery with the lens in these cases. It is technically difficult. The child may have zonular abnormality from the enlarged ciliary ring. The large axial lens and the stretched capsular bag can result in IOL decentration. And any surgery can result in IOP elevation post-operatively, which can deteriorate the glaucomatous optic neuropathy. Also, this patient have many retinal comorbidities, higher incidence of lattice degeneration and retinal holes, and any axial lens more than 26%, 26 millimeter will have a higher risk of retinal detachment. So all refractive surgery have their own complications in this patient. The only refractive solutions that showed good results are the rigid gas permeable contact lens, and in the clever PCG randomized clinical trial, they compared the best compared between the child who used the rigid lens and the child who used the spectacles, and they found greater best corrected visual acuity improvement and greater contrast sensitivity functional improvement in the group that used rigid lenses. So, in summary, childhood glaucoma is a major cause of pediatric blindness. It impacts the quality of life and the academic success of the child. In the poor vision group, low vision aid can maximize functional vision. In the patient with good visual outcome, refractive surgery is contraindicated and shouldn't be suggested for this patient. Spectacles remain the mainstay of therapy, of main method for vision correction. Rigid gas permeable contact lens is a promising tool to maximize visual quality, though it can be difficult to fit this flat and large diameter cornea. Thank you.
Shahira, thank you very, very much for this concise, extremely important message in refractive surgery conference.